I'm Sheila Budoff. I'm with Arlington County's 55 Plus program. I'm delighted to welcome you all to Oh My Aging Eyes, a name we can all relate to. I got the idea for this program when I read somewhere that the FDA had approved a new treatment for presbyopia, which is blurry near vision. And I think it's a condition that many of us have, where you just can't quite get the book far enough or the newspaper far enough. Your arm just doesn't reach that far in order to be able to read. So apparently now there is this new advancement, and there is a simple eye drop that can take care of that. And that brought the idea to mind that there are quite a few conditions of aging eyes, and it would be helpful for all of us to learn more about it and what are the latest treatment advances. I started doing a little research, and I got very lucky, and I was able to find Dr. Ahmed. She is an ophthalmologist right here in Arlington, to discuss several common conditions of aging eyes and recent advances in treatment options. And she's going to take some time at the end to answer your questions. Dr. Ahmed is a board certified and fellowship trained surgeon at the Arlington Eye Center. She graduated magna cum laude from Brown University with a degree in mechanical engineering, and then went on to earn her medical degree from the Medical College of Georgia. She completed her residency in ophthalmology at Tufts University, followed by a cornea and anterior segment fellowship at Baylor College of Medicine. Her areas of specialization include ocular surface disease, complex cataract surgery, laser vision correction, and corneal transplantation. She's a member of the American Academy of Ophthalmology and the American Society of Cataract and Refractive Surgery. So I'm delighted that Dr. Ahmed could join us today, and I'm going to turn the program over to her. Thank you.
Well, thank you, Sheila, for inviting me, and also staying up to date on the recent advancements in therapeutics and making sure that all members of Arlington community can join you on this educational journey of learning more about our eyes. So as Sheila mentioned, I practice at Arlington Eye Center. It's located on the Virginia Hospital Center campus. So hopefully everybody knows where that is. So Sheila did a great job of already telling you about my background, but a little something you might not know is coming out of undergrad in mechanical engineering, I was, gung-ho set on being an orthopedic surgeon. I thought that, I would translate principles of engineering to the human body, and that meant orthopedics. But my third year of medical school, my mom had cataract surgery. I did not even think of the eyes as an organ to actually focus on. And I just remember she had a cataract. The next day she came out and she was so elated that her vision was restored. And just seeing her reaction basically changed the course of my life, as most mothers have that impact on their kids. So, I credit my mom to kind of turning me onto this field, and here, bringing me to this point today. So just a little few fun facts about myself. I love to travel. It's my passion. And I'm sure that many of you, if you have some free time, hopefully are also exploring that. These are just a few of my fun photos. The top right one is in Iceland. The bottom left is in the Highlands in Scotland. And the bottom right is in Morocco. So apparently that's where one episode of Games of Thrones was also filmed, for any of you who are fans. And in my free time, I love to work out. I jog a lot. I've been practicing for 15 years. I trained in Boston. And recently, about 8 months ago, I relocated to Virginia to be closer to family. So that's what brought me here. So there are a lot of topics to cover, but in order for us to understand the diseases of the eyes that I've listed below, I think it's always good to understand and get acquainted with eye anatomy, because that will help you kind of understand the conditions that we're talking about. So I'm going to take you through first a little anatomical primer. So this is an image of the eyeball. This front clear window that's vaulted over the colored part of the eye is called the cornea. Light actually has to bend through the cornea, and what covers the cornea and the white of the eyeball is the tear film. So the tear film is actually the first surface that light hits before hitting the cornea. This other structure below is the iris. That is the colored portion of the eye that we see. And behind the iris is a clear and transparent lens. This is a really young eye. So between the tear film, the cornea, and lens, these are the focusing structures of the eye that focus light onto the back of the eye. And now this back of the eye is the retina. You see this it's a photosensitive tissue that then takes that light signal and basically transmits it down to the optic nerve. So if you think of the eye as being analogous to the old cameras that we used to have, right? Before everybody started using their phones, there was a lens and an aperture that would focus light. And you can think of the cornea and lens and iris as serving those functions of basically focusing light. And that light would be focused onto the film, right? And the film would capture the image. And the film of the eyeball is actually the retina, okay? But the retina, then it translates, it takes that light signal and sends it down the optic nerve to the brain. And then that's how you see. So basically the optic nerve is like a cable that connects the eyeball to the brain. And that's how your visual system transmits light into images at the level of the brain. So our first condition that we're going to talk about is dry eye disease. And I'm sure it's something that we are all experiencing, whether we know it or not, as I like to say. There is no agreed upon definition for dry eye disease. You can experience dry eye symptoms, or you may not be symptomatic and your doctor can look at your eyes and say they look really dry, okay? So it can sometimes be a little bit confusing because some people don't feel like their eyes are dry, and we can look into it and we look at the tear film and we notice that there is like patches of dryness. So let's focus on the symptoms first. Dryness can present as irritation or burning. It's like feeling as if there's a piece of sand or an eyelash that's in your eye. You can often have some redness that is brought about by the underlying inflammation. Dry eye is an inflammatory condition. And sometimes people will say, well, doctor, my eyes are tearing a lot. And you're telling me I have dry eyes. I don't trust you. Why are you saying that? And oftentimes what happens is that if our tear film is not of the good quality and it's not stable, basically it causes our tear gland to try to overproduce the tears, okay? Because it's just not stable, it's not staying in place. And so you get this cycle, a feedback loop of excessive tearing. And if you treat the underlying dry eyes, that can help. In addition, with dry eye syndrome, you can experience fluctuating blurry vision. And oftentimes people who have dry eyes may say, you know what, when I start off my day, my vision's good, but then it gets worse, does this mean I have a cataract, or does this mean I have an eye condition? And the key differentiating factor in these scenarios is that the vision is fluctuating, and the tear film is the only part of your eye that fluctuates. So most likely the blurry vision in that scenario is due to dryness. So this is basically a diagram of the eye. What you see up here, that is the tear gland that produces the lacrimal gland. that produces your tears. And these tears are expressed out onto this full surface. So it covers the cornea and this white part of the eye called the sclera. And so the tears are being produced, and then tears are draining through this drainage system, right? And so dry eye syndrome can either be caused, I don't know if you see my cursor, by decreased tear production, or more commonly caused by the fact that it's not decreased tear production in this second instance, but that the tear film isn't stable, so it evaporates very quickly, okay? So either you have low tear production or a tear film that rapidly evaporates or is unstable. And when the tear film breaks up, that feels like dryness. A normal tear film should stay stable between blinks and shouldn't break up for 10 seconds. So oftentimes when you see your doctor, they'll put some dye in your eye and they'll make you blink, and they're looking at how long that tear film stability is actually lasting. And if the tear film breaks down in less than 10 seconds, we have an understanding that you have underlying dry eye syndrome. So there are many causes of dry eyes. So I'm sure we can all find ourselves in one of these 6 boxes here. So first off, medications. The things that we take that keep us working in other respects, like antihistamines, like diuretics, like antipsychotics, those medications can actually enhance or increase your dryness symptoms. So that's a major factor. Your oral medications may be contributing to underlying dryness. If you have a history of contact lens use, that can exacerbate dryness. One of the most common things in a lot of patients 50 plus is the hormonal changes. And at some level, dry eyes disproportionately affects women, sometimes a lot more than men, due to menopause and the declining estrogen levels. And so all our mucous membranes dry up, and the eye is a mucous membrane. And so you can have enhanced dryness following menopause. In addition, if you had thyroid dysfunction, that can enhance also the dryness that you experience. If you've had prior laser vision correction, you may have had great vision when you were younger, but the nerves sometimes do not generate to the same level as they were, because laser vision correction basically cuts into your cornea. So it inhibits the feedback response to produce a lot more tears. So you can have some baseline dryness with it. If you have glaucoma and you're on eye drops, well, some of the medications, the topical medications we put you on, can also induce some dryness. And then there's just the environmental factors, right? We are spending a lot of time on our digital devices, on our laptops, on our iPhones, on our iPads. And so we're just kind of constantly glued to our screens. And sometimes we forget to blink, or we have a decreased blink reflex. Or you may find yourself in high flow environments where the air conditioning is flowing, and that's just kind of contributing to that broken up tear film. Or I have patients who have sleep apnea and they're on a CPAP, and that oxygen is blowing through the canning line. Guess what? The eyes are getting that high flow of oxygen, and they wake up and they say, the eyes are red, or all day it's bothering them because of other treatments, right? So all of these things can affect your dry eye symptoms. So in terms of topical medications, there are a lot of choices out there, okay? There's the regular eye drops. They come in many variations. There are preserved eye drops and preservative-free eye drops. Then there are gel drops, and then there are lubricating ointments. So traditionally, an eye drop that had preservatives in it typically came in a bottle. So in most of the Walmarts, Targets, pharmacies that you go to, you can purchase a bottle of eye drops, and it won't say it has preservatives in it, but what you'll notice is besides every brand, like let's say the regular bottle of Sustain or the regular bottle of Genteel, there'll be a more rectangular box that has vials. And on that box, it'll say preservative free. I strongly believe that as we get older, we should choose the preservative free drops because preservatives such as BAK, also known as benzalkonium chloride, can also be toxic to the surface. So you're trying to solve a problem with a problem that might hurt you. So I think choosing preservative-free drops is ideal. Because they come in individual vials, you can only use it for, they say one-time use, but you can use it a couple times during the day. There's a lot of drops in that one little vial and it's costly. So just, store the vial in a clean box and throw it out after 24 hours once you've opened the vial. Gel drops are useful. They're a little bit more viscous, so it can feel good, but sometimes it can come at the expense of blurring your vision a little bit longer. And so if I have patients with severe dry eyes where the preservative-free artificial tears aren't fully helping, I may ask them to also supplement with gel drops, something more viscous. And then lubricating ointments. Oftentimes I'll have patients who have, wear a CPAP or who had a history of Bell's palsy and they couldn't fully close their eyes. I will tell them to actually, it's a lubricating ointment. You just pull down your lid, put a strip of the ointment in, and usually I prescribe that or I ask them to take that only at bedtime because your vision's going to be blurry and it's going to goop it up. So that's when people have very severe dryness, and oftentimes I'll have them use it at night. All of these brands are great. I feel like there's no one brand that gets my seal of approval. They all have different formulations. They're over the counter. They've never really been studied head to head in an FDA trial. For me, it's all trial and error. I'll tell a patient to use Sustain. If they liked it, great. If they didn't, use Genteel. And just figuring out what works best with their body. One other thing is after artificial tears, we've maximized on that. Oftentimes, if patients are still experiencing dryness, there are a few other things that we can do together. So in the clinic, we can either put you on prescription medications. You may have heard of Restasis or Xiidra, and those are things that we could then prescribe you that actually work against the inflammatory pathways that are involved in dryness. So I often say that with dryness, artificial tears are just like the baseline lubrication that keeps your eyes working. And then the medicine basically improves the quality of the tear films that you're producing. You'll also have other adjunctive therapies, such as I had shown you where the drainage system of the eye is. Sometimes we'll plug those drains up with a punctal plug. And so there are other things that we can do to help you retain your tears. So I'm going to now go to presbyopia, and we can go deeper into each subject, but I kind of on purpose kept it high level. That way we could cover many more topics. And presbyopia is what prompted Sheila to reach out to me. So this is a fun one. So why do we use reading glasses? What happens to our eyes over time that kind of make us go from being able to see perfect at distance with our glasses or contacts to now struggling up close and feeling like we have to grow an extra pair of arms to see the fine print? Well, when we're young or younger, our lenses are nice and clear and they're flexible and they can basically change shape much more easily. So over here, the lens is flattened. When it needs to focus up close, it kind of, balls up and it can focus on objects up close. But what happens with presbyopia, basically it's the loss of near vision due to the inability of that lens to flex like it used to when you were younger. And because that lens doesn't change its shape and doesn't help change our focal points, we end up needing magnifiers to supplement our ability to see up close. So, Vuity is the first FDA-approved eye drop that helps target this underlying issue. And one of the things it does is Vuity is something called pilocarpine. Pilocarpine is a drug that's been around forever. We use it in glaucoma, and basically how pilocarpine works is it works on the muscles to constrict the iris, and it also constricts the other muscles. And as you're constricting the iris, you're basically bringing the pupil down and you're helping focus light and creating a little bit more depth of focus. So there's a little bit of a pinhole effect. And so it's not creating a full pinhole, obviously, but it's that relative constriction of the pupil is actually giving you a little bit more near vision. So it's been approved for once daily dosing. And the important thing about it is that it takes 15 minutes for you to start to notice an effect. And the effects of Vuity can last up to 6 hours. Okay. A lot of the studies also looked at 3 hours as the endpoint. The ideal patient for Vuity typically ranges from ages 40 to 55. In terms of, let me just move this out of my way. In terms of your vision, it works best in people who have a distance vision of 20/20. Okay, so if you're naturally 20/20 or you wear contact lenses all the time and you're basically trying to rid yourself of readers, then putting the Vuity will help constrict your pupils and you'll get that added low level, the added effect of a magnifier through the pinhole constriction. Vuity, when you're using that drop, basically gives you about the equivalent of a plus 150 over the counter reader effect, right? So if you are requiring a +2 or a plus 250, Vuity is not going to get you the full way with the up close reading. So I think it's a great drop. Definitely can help a certain segment of the population. In terms of the outcomes, what we were able to gain with Vuity is basically if this left side chart is what you were able to read up to this point, let's say with near vision, Vuity gave you 3 extra lines of near vision after using it, right? But the effects wear off after 6 hours. And this effect comes at the expense of you're getting 3 lines of near vision focus, but you're losing 1 line of distance. So I would recommend that for, if somebody knows that they're just going to be doing a lot of computer work and doesn't want to wear their glasses, or maybe they're, giving a virtual presentation and they just want to be able to see the screen. And that, you're going to be in meetings for 3 to 6 hours. You can put a drop in, 15 minutes later, start to notice the effects and take advantage of the medication. The side effects of Vuity can include a mild headache and some redness and irritation. In some of the study data, you'll see that they talk about the theoretical risk of a retinal tear or retinal detachment, and I don't believe any occurred in the trial. And so it's a theoretical risk. It's not anything that would make me, discourage anybody from trying the medication. Next, we're going to go to cataracts. And cataracts are basically a clouding of the lens. Basically, when you have a cataract, your lens goes from, you're born with lenses that are nice and clear and that can focus light very easily to the back of the eye. But when you develop a cataract, this nice clear lens basically over time ages. And as it ages, it becomes yellow and hazy, and it enlarges and it becomes more rigid. And so you have less light reaching the back of the eye through this yellow hazy lens. And you also have scatter of the light and inability to properly focus the light because the lens is not clear and transparent. So how a cataract will manifest in your day-to-day life is very blurry vision. And you're going to have trouble seeing objects at a distance or reading the fine print up close. You may not realize it, but you have decreased contrast sensitivity. Oftentimes, patients after cataract surgery will tell me that the whites are so much whiter they didn't realize what they were not seeing. At nighttime, because of the lens diffracting light, you can get increased glare and halos. And so this is an example, this top left image. So this is a normal image vision through a healthy eye. And then this is an image simulator. And basically, when you have a cataract, the vision blurs, right? And this is probably a mild to moderate cataract. You're able to see things away, but it loses its definition, its contrast, its sharpness. And so cataracts progress very slowly over time for most people. And so they might not realize where their reference or baseline point was. And, for a little while, they'll say, well, it's not that bad until like they really can't see the signs while they're driving. And then, those ends up being the cues that bring people into my office. So with cataract surgery, we've had many, many advances, and those advances are great, but it also translates into many choices. So oftentimes, people will come into the office, and these end up being a little bit lengthier discussions because there are two questions that we have to answer. First is, how do you want us to perform the cataract surgery? And oftentimes people are like, perform it the way you should, right? But now we have choices and technologies, and the unfortunate reality that some of these technologies are not covered by insurance. And then the second question that we would want to answer is, well, what are your visual needs? What are your visual expectations? Because based on that, we can have a conversation about what type of intraocular lens to implant. So just to back up, we have a cataract on the left side. It's kind of scattering and decreasing light transmission. And cataract surgery is basically a removal of this lens from the current bag that it's in. And then you're implanting this nice artificial lens here that can fully transmit the light and doesn't diffract it and improves your ability to see. So in terms of cataract surgery, how is it performed? There are manual and traditional methods of how we perform cataract surgery using our hands and our tools. And then there are advanced laser-based methods where the laser locks onto the eye and actually performs key parts of the surgery. In terms of the intraocular lens implants, we have what we call monofocal lenses, which are lenses that are focused to one point, versus lenses that can give you a range of vision. So I'm going to first show you a little video, and this is just a short clip of cataract surgery using a manual technique. We've made the incisions in the eye, and we're actually right now making a circular tear with our instrument right here, and hopefully this will play. So basically, we are making a circular tear in the bag that holds the lens, because now we have, after we make that circular tear, we are going to be going in, breaking up that lens and sucking it out, and then putting that nice artificial lens implant. Okay, so what may not be evident to you is that the tissue that we're tearing is actually 20 microns thick. That's 20 times 10 to the negative 6, right? It's very, very thin tissue, and we're all doing this manually. That manual techniques have worked great for quite a while. And sorry, let me just, but we also have laser-based cataract surgery, and this technology is really cool. I'm showing you just different parts of the surgery. So with laser-based cataract surgery, we actually have a laser that docks. I'm going to play it, and then I'm going to skip forward to 1 minute so that you're not, you don't have to look at all the scans that we're verifying. But basically, we put you under the laser, and the laser docks. And as you're docking, basically, we'll turn this on.
You're doing great.
And so what you're going to see here is that at this point, you know, the laser is putting on these overlays of where the incision is, where that circular tear will be, how to break up the lens. And so it's actually doing all these key components. And I am going to forward to about 1 minute where you'll actually see the laser working. And so we have to do a bunch of checks. And so what you see here is basically once we've done all the checks and we turn the laser on, we basically have 24 seconds and that laser is docked, and now it starts to make all of the incisions and does the crucial parts of the surgery, which is making that circular tear, and then it's going to break up the lens, and then it's going to make the side incision. So I'm going to just have you see that.
15, 10, 5, 4.
Okay, so let's see. So basically, those are two different ways of actually doing cataract surgery. I would say with the laser, we can treat low levels of astigmatism by doing incisions in the cornea. And I would say that the laser is just a very precise, cool technology. And everything is perfectly centered. So you're really like choosing the actual precision and ability to treat low levels of astigmatism. And I would say that is the advantage of the laser. In terms of outcomes between manual and laser, I would say that overall outcomes for both are good. And so, my patients, I always give them the option. And if they have some astigmatism, or if they're looking to do premium lenses, the laser is definitely packaged in with that for if they choose so. So now the second question that we were mentioning that we have to answer with cataract surgery is, what kind of lens should we put in your eye? What right now insurance covers is what's called a monofocal lens. It's a standard monofocal lens, which means that when you put this lens in the eye, we can correct you for one focusing point only. So if you look at this picture, this is a visual simulation, you have 3 focal points for vision. There is distance right here, this computer far away. This intermediate computer right here, that is your intermediate vision. And then your phone is the near, okay? And if we put a monofocal lens in, this lens is plastic. It doesn't have that focusing capacity of your lens when you were young. This lens isn't gonna move. We basically do these fancy calculations and we order a lens of a given power that can give you good distance vision, but then you would have to wear glasses for intermediate and near work. And so this is an excellent choice. It's covered by insurance. If any patient of mine comes to me and says, "Doctor, I want to see well at distance and not wear glasses," this is a great choice. And this choice is predicated on the fact that the eye does not have astigmatism, because that definitely changes the overall vision. So if you have an eye that doesn't have astigmatism and you just want to see well at one focusing point, the monofocal lens is covered by insurance and it's a great option. But we also have other choices. This is a depth of focus lens. And what you can see here in this lens is that there's like a little bit of a central button where the architecture of this lens is such where you have a bit of curvature in the center. And that curvature gives you some amount of intermediate vision. So in this image, you'll see that through this depth of focus lens, you're seeing well at distance, you're seeing pretty good at intermediate, but the near may also be a struggle. So I would say that this lens gives you a distance to intermediate range, and you would still need to wear low-level reading glasses if you'd want to see things up close. So I like to put these lenses in people who are active and maybe they drive a lot at nighttime, because some of the multifocal lens technology is a little bit more complicated, and I'll show that next. The multifocal lens, this is a lens, as you can see here, it doesn't show up as well on this image, but this is a retroillumination image of the lens as it's implanted in the eye. You see multiple rings here. These are all distance, intermediate, near prescriptions on here, right? So, sorry, I meant to say it has two really good focusing points, but then a third okay focusing point. So with this multifocal lens, you can get great distance and near, but the intermediate is a little bit compromised, okay? And I would say with multifocal lenses, there is about a 10% chance you could experience some nighttime glare and halos. And so, it's hard to predict who will experience some glare and halos. When we put these lenses in, I like to put them in both eyes that are being done. And your brain tends to basically adapt over the next few weeks. And I think the patients who love them tend to be people who don't drive a lot at nighttime, and they read a lot, they knit a lot, or do up close work, and they just want to have really good distance and really good near. And I think that there's no such thing as a perfect lens for everybody. There's understanding what lenses exist and who would best be suited to that lens. And then I wanted to touch briefly upon astigmatism. We've all heard the term. It's like the one term in ophthalmology that every layperson knows about, and I think it's because at the root we have the word stigma in it. And astigmatism basically can cause blurred vision at all distances, and it's based on how the cornea or the lens is shaped. So instead of being shaped with a perfect curvature that's even, like a basketball has an even radius of curvature, it's kind of, I would say, shaped more like a football, right? If you cut a football lengthwise versus widthwise, you have different shapes because the surface is not curved the same way consistently. So with astigmatism, you can get blur at all 3 points. So if I put in a standard monofocal lens, the first lens that we were talking about, in a patient with astigmatism, without glasses, their vision would still be blurred. They'd have to have the astigmatism corrected in their glasses. So if you are looking to be glasses free at distance and you have astigmatism, in order to get that, in order to achieve that goal, we would have to put an astigmatism correcting lens, or what's called a toric lens, and we would help focus that for distance. And then you would still need glasses for intermediate or near vision. Now, the one exception is we can also put in a depth of focus or a multi-focus lens that has astigmatism correction built into it. And so in those situations, then you would get the distance intermediate or distance near corrected. And you would not be confined to just seeing distance. So there's a lot of lens choices out there. So hopefully those choices were not too overwhelming. We're now going to progress to the back portion of the eye, called the macula, and I think the retina. And you know, macular degeneration is something that is top of mind for everybody. And you know, rightfully so, because it's the leading cause of vision loss in people 50 years or older. And you know, macular degeneration comes in two forms. There's the dry form and the wet form. Okay, so over here, this tissue, all of this is the retina, but this central area of the retina, that is, you know, where light is perfectly focused onto, that is called the macula, and it's responsible for your central vision. So it exists between these arcades of vessels and the optic nerve, and it's right here. And that is a normal macula. There's a little bit of darkness to the coloration there. With dry macular degeneration, you can get these age-related deposits called drusen. And these deposits basically interfere with the functioning of the retina. And that's called dry macular degeneration. When you have bleeding associated with these drusen and pigmentary changes in the retina, that's what we call the wet form of macular degeneration, and that tends to be a lot more visually problematic. So macular degeneration affects the central vision, as we stated, and the risk factors for this condition are numerous, but it also includes being older than 50, smoking, a history of high blood pressure, being overweight, if you have a family history of macular degeneration, or you're having diets high in saturated fats, like a lot of meat and butter. So I often think that it's always helpful to see these visual simulations of how these different conditions affect you. So the top right corner is a picture of two kids playing with their balls, hugging, right? That's what you're able to see with a healthy eye. But with macular degeneration, you have just a wiping out of that central vision. And so you'll retain your peripheral vision because the peripheral retina was not damaged by the accumulation of drusen or the bleeding. That's all central. So, you know, this can be very traumatic. I think some of the best things we can do is that monitor and help prevent, right? One of the things I like to encourage patients to use, and I give them in my office, is something called a Amsler grid. In an Amsler grid, basically you look at the center dot of the grid and you do it one eye at a time. So you cover up, let's say, your left eye, look at the center of that dot and make sure that you see all lines and making sure that they're straight and there's no area missing. And then you cover up the opposite eye and test that eye, because you don't want to just do it with both eyes open, because each eye might be compensating for the other and you might not realize or see the defect. Oftentimes with macular degeneration, when you're doing this test and you'll notice a patch where the lines are wavy or the vision is missing, that's a sign to call your ophthalmologist and get examined, because it could be that the dry form of macular degeneration has, you know, turned wet, or there's some sort of advancement. In people who have some level of vision that's already distorted, I tell them to outline the area of visual distortion and then keep on looking at that grid and monitor for any new areas. Now, we do have vitamins that we recommend for people who have the dry form of macular degeneration. It was not studied in patients who just had no evidence of macular degeneration. So I always emphasize to patients, you know, if you don't have any macular degeneration, don't take these PreserVision or iCaps vitamins, because they're really high vitamin formulations, and anything in high doses could also have negative consequences. I just encourage my patients who have normal eyes with no signs of macular degeneration to take a normal multivitamin and eat a lot of green leafy vegetables. But in those patients who have the dry form of macular degeneration, I recommend that they take the AREDS 2 vitamins. And these are two brands that are commonly used, Preservision and iCap. And it basically contains the recommended formulations of vitamin C, E, lutein, zeaxanthin, zinc, and copper. We don't have any treatments for the dry form of macular degeneration. It's just let's monitor and take the vitamins. Now with the wet form of macular degeneration, we do have treatments. When there's blood, there are two ways to approach it. Injections are the most common and effective method that we use. We have medications called Eylea, Lucentis, Avastin. There are anti-vascular endothelial growth factors at the very long term. Basically, it prevents new blood vessels and bleeding from forming. You want to attack any new blood as quickly as possible because you don't want to form a thick scar at the level of the retina, because when the retina scars in that area, you've lost vision. Other things that we propose are using laser treatments to actually coagulate the vessels that are leaking. So, I always defer to our retina colleagues regarding, what treatment options need to be further pursued. I'm just looking at the time. I'll quickly fly through glaucoma. So glaucoma, as I said earlier, the optic nerve is like the cable that connects the eyeball to the brain. And so when there's damage to that optic nerve over time, glaucoma represents the damage to that optic nerve. And it's due to many factors, but eye pressure is a major factor. It's the leading cause of blindness over the age of 60, and there are two varieties. There's open angle and narrow angle. I'm just going to talk about the open angle. It's also known as the silent thief of sight, okay? Because glaucoma tends to affect the peripheral vision before you sense any loss of central vision. So risk factors include being over age 40, having a family history, having an elevated eye pressure, but you can also have normal pressure and low pressure glaucoma, which can sometimes be very confusing that, the pressure is normal, but you still have been diagnosed or given the label glaucoma. It's more prevalent in African, Asian, and Hispanic heritages. People who have a history of diabetes, high blood pressure, and migraines are at high risk for developing this. Also, people who are on steroid use are at higher risk. So top right image, healthy eye. Now you'll notice the bottom left image, you're getting a little bit of tunnel vision. Glaucoma is very insidious. You start by losing some of the peripheral vision, and both eyes have such wide fields of peripheral vision that they compensate, but this can encroach basically gradually on central vision. And as it's affecting your central vision, that's when a lot of people start to have issues where they're missing the steps that they can't see when they're walking, right? And they may have fallen, and that's when you actually start to notice the visual impacts, which is why it's very important to see your doctor earlier on just for normal eye exams. There are many treatments. There's eye drops that can help control it. There are laser treatments. These are the non-invasive treatments. There are minimally invasive therapies that we can do at the time of cataract surgery, where we can stent or open the drainage system of the eye. And then there are more invasive surgeries that basically you can use a tube shunt to shunt fluid out of the eye and lower the pressure, or create a reservoir underneath the eyelid, underneath the conjunctiva, to allow fluid from the eye to escape and also lower the pressure. So I know that was a lot to cover in a short period of time, but I want to thank you for giving me this opportunity to speak. And if there's only one thing that you can take away from this, I would say just, make sure that you get an eye exam. I know that at the beginning of this, somebody had said, can you tell me the difference between, you know, an optometrist, an ophthalmologist? And so I'll just address that point. With optometry, they go through optometry school, and then, you know, usually would prescribe glasses, contact lenses. Every state has different rules. I was in Massachusetts where they could not treat any of the medical conditions like glaucoma. Here in Virginia, they have a larger scope for treatment. With ophthalmologists, we go through medical school, and after medical school, go through residency training. So that's a 4-year process, and then do fellowship. And, you know, we're qualified to treat all medical and surgical conditions of the eye. So that's the one difference in terms of the terminology. And then opticians are people who go, you know, you can go to with your glasses prescription, and then they would make your glasses. So just to break down the 3 differences, but I'm going to pause there and give you time to ask your questions.
There were several in the chat as you were speaking.
Yes. So beauty is not for us if we are in our 70s. I would say that if you've had, so according to the company, they would say otherwise. They would say, well, if you've had cataract surgery and you have a monofocal lens in, and so now you can see well at distance, you could still use beauty. But I don't think it's ideal because, you know, once you have cataract surgery, most people are requiring the +250 reading prescription. And, you know, beauty gives you the effect of a +150 reader. So I think you're still going to be frustrated unless you just happen to purely be doing intermediate related tasks. And the other thing I would say is after cataract surgery, people's pupils tend to be a little bit smaller. So I don't know how much of the added effect of pupillary constriction you'll have to give you that extra bump. So I personally wouldn't recommend it. Or, you know, if you want to try it, get a sample from your doctor before paying for it and trying it out. But I think the ideal group of people is from 40 to 45 who haven't developed a cataract and who have already perfect distance vision or corrected with contact lenses and they just don't want to use readers. On what basis would you choose manual versus laser-based surgery? I love technology. I love precision. I love treating low levels of astigmatism. So I'm a big fan of the laser. I just love the perfection of like just where you're making that central opening, because how you make the opening is how the lens centers. So I find that I'm a fan of it. I usually leave it as a choice to the patient. I would say, you know, if they ask me, what are the outcomes? The outcomes of manual cataract surgery and laser-based cataract surgery in terms of, you know, making sure you don't have any adverse incidents or whatever, are relatively similar in a well-trained physician's hands. I just think it gives you that ability to treat that low level of astigmatism, and especially if I'm putting premium lenses in, I always do that because those premium lenses, like the multifocal lenses, have to be perfectly centered, and that opening has to perfectly center on the lens. So I don't like to take any chances. It wouldn't affect, I just think it's very precise. Now, that being said, I tell people, if this is out of your budget, I'm actually taking you from a place of deficit to improvement with manual-based cataract surgery. I don't want anybody to feel like they're getting an inferior product. Both improve your vision. It just depends, like if I'm using an upgraded lens or not, and whether there's low levels of astigmatism. But the actual results of just physically getting the cataract out and putting the implant in, I think are very similar. So beauty eye drops can be used with contacts in the eyes. You have to put the drop in 10 minutes before with your contact lens outside of the eye. So I would put the drop in and then 10 minutes later, put your contacts in. I wouldn't use the drop with your contacts in place. What are the adverse effects possible from taking AREDS2? So the reason why we always have these precautions is, with these high doses of vitamin or high doses of beta carotene, it was, people who had a history of smoking had a higher incidence of lung cancer when they're on these high dose vitamins, right? And so there's just these like risks of taking high dose vitamins in people that may have other underlying conditions, right? And so I would not necessarily, if you don't have macular degeneration, I don't think there's any need for you to expose yourself to a high dose vitamin formulation. AREDS, take the AREDS lutein vitamins as different from AREDS2, which are specific to macular degeneration. AREDS2 basically has the lutein. I think it's quite similar. I'm not sure. I think the AREDS, it's all marketing. Some will say AREDS vitamins with lutein. I have a feeling they're all following the AREDS2 formulations, but if there's any confusion, just look for the AREDS2 labeling. So let me just look here. My husband, who is in his 60s, recently has been bothered when he was facing brightness, windows with no curtains or light bulbs. It never used to bother me. What is the cause, and is there a remedy other than looking away from bright lights or windows? So Rosmunda, I think that when you have bright light, there are a couple of things, and you're having a lot of light sensitivity, there are a couple of things that can cause that. There could either be at the level of the tear film, where if you have dry eyes and that tear film's really patchy and not regular, it can scatter light, or it can be at the level of the lens. If you're developing a cataract and that lens is now cloudy, it can also backscatter light, and that scattering of light gives you the glare effect, right? Where you don't want to look at headlights or bright bulbs. So that might be it. The only way to verify that is through an exam, but I think it's most likely one of those two. So could we say if one is in good health, one can delay the onset of some eye diseases? Yeah, high blood pressure, diabetes, those are risk factors for a lot of things. There's always a genetic component, right? Family history is associated with glaucoma and macular degeneration. But I think I would just advocate for being in good health in general. And, sometimes it's genetics versus the social factors, right? Or environmental factors that can trigger disease. And so if you're controlling your social environmental factors, I think it puts you in a better position for hopefully not developing or manifesting some of these diseases. Do you recommend doing both eyes at the same time for cataract surgery, or one at a time? So this is an interesting question. I do know very few people who do surgery on both eyes. I am not a fan. The majority of cataract surgeons in the United States typically do not do surgery on both eyes at the same time. And there are a couple of reasons, right? When you're in the operating room and you're using instruments, if there was ever some sort of like outbreak or some sort of sterilization issue, right? Now you've exposed both eyes to that potential risk. And it's never happened to me, but those risks exist. Sometimes you can have an outbreak of just, instruments are cleaned a certain way with certain chemicals that can cause inflammation in the eye that's much more than would normally occur in the eye. And so I always think it's nice to, first of all, you don't want to expose any breach in the surgical environment or the protocols. You don't want to expose both eyes to it. So that's one reason to do each eye separately. I would say The second reason why you don't want to have both eyes operated on is I like to see are you happy with the vision in the eye that I operated on, right? We have all these lens choices, right? And let's say you went for a multifocal lens, right? Or you go for a normal monofocal lens. I want to make sure if we chose distance that you're not requiring any prescription at distance and that we've hit the target that's based on our measurements. And if we're off a little bit on the target, I use that information to adjust my lens choices in the other eye. So it's also my way of fine tuning things so that you're able to hit targets and have great vision in both eyes. So I'm a big fan of wait, let's make sure one eye is healed. Let's make sure you're happy. Let's make sure there are no issues. So my question was whether people who don't have macular degeneration should take AREDS lutein. No, I would not recommend it based on the data. There were no studies done on patients who didn't have it regarding whether taking AREDS with lutein benefited them. All studies were done on people with dry macular degeneration. So the very edge of each of my eyes, far right and far left, feel irritated and sting a bit. I put moisturizer there, which is temporarily soothing. What causes this and how to remedy this? So yeah, a lot of times when we sleep, we can develop some crusting and accumulation of material in the outer corners. It's like scurf. We call that blepharitis. And usually when I see it, I put people on a lid hygiene regimen. So I'll have them do warm compresses to loosen up that material. I'll have them use lid wipes after they've, warmed up the eyes and wipe the lids, back and forth to remove some of that crusty material. And then sometimes I'll put them on a little bit of antibiotic, like an erythromycin ointment that decrease the bacterial burden on the eyelids that form that material. So I think that would most likely be the reason, but one wouldn't know until one examines. If you go for premium lenses, would Medicare cover part of the expenses, or do you have to pay for it all for yourself? No insurance covers any of the upgrades, and that's been an issue. So insurance covers standard cataract surgery and standard lens implant. I went into medicine to just kind of like deal with the medical portions of it, but as you realize very quickly, you have to deal with insurance, you have to deal with legal issues, you have to deal with everything, right? And in an era where there are new technologies being put out there, it ends up being the doctor's responsibility to actually discuss those lens choices with their patients, even though they're an out-of-pocket expense. Because we want to make sure that you have informed consent and you understand your choices. And there are legal implications to that. There was like a lawsuit many years back where a doctor in Florida didn't discuss these other lenses, and a patient got mad because they were like, well, I would have paid for it, right? So all sorts of things happen. And so you end up now having to discuss what's covered, what's not covered, and making sure that people have all the information, because you can never assume anything about what people desire. So I wish finances was something that one didn't have to discuss, but that's our basic reality. Is the risk on AREDS 2 the same for former smokers? Yeah. So we say that if you actively smoke or were a former smoker, there's a smoker's formulation. So any other questions? I hope you all feel a bit more empowered and feel like you can, come to your eye doctor with some, baseline of information about what all of these diseases mean. And you can always find me. I'm at Arlington Eye Center, but if there are ever any questions, or you have certain questions after the presentation, let Sheila know. She can forward them to my email account and I'd be happy to answer them.
Thank you so much, Dr. Ahmed. This was outstanding. I really appreciate you taking the time to explain everything and answer all the questions. This was wonderful, very informative. Really appreciate it. Thank you.
You're welcome.
so much.
Hopefully all of it was comprehensible. I would also appreciate if there are things that didn't make sense or you have any feedback, please let me know. It always helps me to know where there might be disconnects and how to better communicate with my patients. So any feedback that could have helped made this a better presentation or pieces of information that you wanted to know, please email Sheila and she can forward me the list of requests, and I would really appreciate that.
Absolutely. Thank you so very much, Dr. Ahmed, and thank you to all of our participants. We really appreciate you joining us. Thank you all. Stay well and go for your eye exam. Don't forget.
Okay, take care.
Thank you all. Appreciate it.
Bye-bye.